Great. Thank you guys for joining us this morning for May case reviews. I appreciate your guys' time to review these cases. As we move forward, as always, this information is confidential and privileged. It's protected by HIPAA, and we should not be discussing it, distributing it, or copying it to anybody outside of our agencies. Without further ado, case one. Case one is of a 62-year-old female that EMS was dispatched to a nursing home for regarding a woman with abdominal pain that was morbidly obese. The primary survey was that she was awake, she was oriented, her airway was open, she was protecting it, her skin was pink, warm, dry, and she had no signs of active bleeding. Vital signs, I report to you guys in the initial assessment if they've been recorded within the first 10 minutes. There were none, so I have no vital signs to report. And her weight was documented as 537 pounds. So her BMI based off of her weight and height was 85, which puts it at severe morbid obesity. Her past medical history included cellulitis, morbid obesity, hypertension, and hernia. They documented that she was on pain medications in the form of hydrocodone and Tylenol, and that she was on the anticoagulant warfarin. The history that was documented was that this call was a priority 5 to a nursing home with abdominal pain and complications from a hernia. The staff at the facility had said while she was being rolled, she felt her intestines pop out of her abdomen, and that she was seen for the same thing 2 days earlier with that transport question to being able to see her bowels. She was told that she did have a pinhole section in her abdomen and that her pain today of the date of service is at her baseline. The call was initiated at 6:27, or at least patient contact occurred at 6:26 in the morning. The first set of vital signs were recorded at 28 minutes after patient contact. She was known to be tachycardic at 104. She had a blood pressure 116/52. No respiratory rate was recorded at that time. It sounds like there was some delay in getting her transported due to the need for a bariatric bed and able to extricate her out. So they had to wait for the bed to arrive. They initiated transport at 29 minutes. The patient had refused an IV. At 34 minutes, a full set of vital signs was obtained. Still tachycardic at a rate of 104. Blood pressure, same at 116/52. Respiratory rate at 18, SATs of 96%, and temperature documented as normal at 98.8. They initiated transport as a code yellow. In addition, in the physical exam, there is no mention to her bowels visually being inspected. 49 minutes, another set of vital signs were obtained. Heart rate of 100, blood pressure 110 by palp, respiratory rate of 18, SATs of 95%, and at 54 minutes, she arrived at the hospital. So in reviewing this case actually came up because of hospital concern. Hospital concern that it was, number one, not a code red because of the reports of an evisceration, and number two, because there was not a Pulsera documentation, and basically those were the two reasons why this call was brought up to the MPD's office. In reviewing this case, I thought that serial vital signs were appropriate. They attempted to place an IV, although the patient refused. And given the information, besides the tachycardia, this patient appeared to be appropriately code yellow. In speaking with the crews about this case, they did evaluate her abdomen, but they did not document it in their physical exam. Areas for improvement, time to first vital signs. We should be doing our best to get vital signs within the first 10 minutes. Making sure to document the physical exam as you find it, especially important information. Not forgetting to manage eviscerations, which I guess we can talk about right now, would be not to push the bowels back in, and also to use a saline-soaked gauze over the bowel to help prevent it from desiccating or drying out. And then making sure that we notify our hospitals partners that if we have a confirmation of an evisceration, that needs to be in the notification for the hospital, and ideally Pulsera, but if it's absolutely impossible, as this crew did a HERE report, making sure that the hospital is aware of evisceration. So in the emergency room, they noted that she had a ventral hernia that had ulcerated, and there were approximately 2 feet of bowel protruding from the wound. She was found to be COVID positive. She got IV fluids and antibiotics. Surgery was consulted at Peace Health, which was unavailable due to her complexity of her morbid obesity and poor wound healing. So she was transferred to OHSU. At OHSU, her diagnosis was an incarcerated hernia with intestinal herniation. She underwent an XLAP with lysis of adhesions and bridging vicral mesh, as well as a wound vac. She became more hemodynamically unstable. She became septic, and given her comorbidities, her current COVID infection, and her unlikely to have a good prognosis, the family had moved her towards comfort measures, and she was pretty sick. It sounded like she was on pressors, antibiotics, was intubated, and wasn't doing any better with poor organ function. So her family made her comfort measures, and she passed away on hospital day 4. This picture is of her presentation 2 days prior to Peace Health. The physician had documented some pictures of her abdomen. And to give context, her head would be up here. That's where her gown is. And this is her belly from feet pointing towards her head. So these are probably the ulceration that led to the evisceration of her bowels. But you can see that she had pretty protuberant abdomen, poor wound healing, and just not a great mix for her condition. So I thought this would be a good case to talk about because I think that we don't see a lot of eviscerations, and we're speaking in this case of abdominal evisceration, and especially not in the context of a medical caused evisceration. We tend to think of it as trauma, either that's from a stab wound or a deep laceration, but it also could be from poor wound healing from a hernia like this patient, or that the patient had a recent surgical incision and like a laparotomy, and that they're having some bowels protrude from that. In regards to abdominal eviscerations, we're speaking to abdominal contents, but there could also be rectal evisceration, which we tend to think of it as more like rectal prolapse. But in reviewing this data, that outside of rectal prolapse, there could be other sorts of rectal eviscerations. So there's not a bunch about medical eviscerations in my review. So in general, I just thought I'd talk about, you're going to manage their ABCs if they're hemodynamically unstable, IV access in this patient. Any of these patients would be considered potentially critically ill. So consideration of 2 IVs if time allows, IV fluids if the patient is hemodynamically unstable. In our regards to our trauma patients, we're looking to aim for permissive hypotension. And then in saline soaked gauze, don't push the wound back, don't push their bowel contents back in. All of these patients, medical or traumatic, are going to need a surgeon for repair, and they'll be getting antibiotics. And if they have their abdominal contents outside of their intra-abdominal cavity, these patients are going to go to surgery. So I thought I'd pull up what we have for eviscerations in our protocol. In our protocol, we speak to them in regards to death in the field. So a indication for having a field pronouncement, so evisceration of the heart or the brain. We don't speak specifically to eviscerations, but we cover that. I believe we even covered it even in the EMT basic protocol nationally and at the state level. So we would also cover that at the ALS level as well. And then I thought that in regards to this patient, the most appropriate protocol outside of the evisceration management would be talking about pain control. Ideally, we'd be getting a pain scale from this patient. They documented that her pain was at baseline, but getting a number would be also appropriate in addition to documenting that it's at baseline. Treating the underlying causes, using non-pharmacological management as a mainstay in all of our pain management cases. Options would be Toradol, but contraindicated in anybody that is on anticoagulation, as this patient, as well as renal liver disease, trauma cases, aspirin NSAIDs, pregnancy, bleeding disorders. Opioids are also a potential, but we avoid using them in chronic pain syndromes. That's more in regards to chronic migraines, but I think you can also consider this as a chronic pain syndrome where she's documenting that she's indicating that this is her pain at chronic level and that she's on meds to also support that she has chronic pain. Ketamine to be given after 2 doses of fentanyl have not created appropriate pain control. And then for certain agencies, nitrous oxide is a option. Anybody have any questions about this case? Thoughts? Things to add? Is there somebody that wanted to say anything? All right. Then in that case, we'll move on to case 2. This is a case of a 53-year-old male who was found down at a local hotel. EMS made contact with the patient, noted that he was altered. He was in respiratory distress. Primary surveys, this patient was unresponsive to painful stimuli. His airway was open, but he wasn't protecting it, and he had agonal respirations. As for circulation, he was found to be pale, cool, clammy. Vital signs were obtained by the fire department before transporting agency arrival, and they noted to be tachycardic at a rate of 124, hypotensive at 75/48. No respiratory rate was recorded, and the patient was estimated to be 100 kilos. Past medical history is unknown, but given the context, they felt that this was probably substance abuse and that he had some evidence of IV drug use on his physical exam. The medical history was unknown as there was nobody around him. The staff at the hotel found him, and they found him unconscious, unresponsive next to the elevator. No available history preceding or upon his arrival. This call occurred at 12:10 p.m. Or actually, let me rephrase that. This call, transporting EMS made contact at 12:10. They started with bagging the patient. They noted that he had track marks and that he had agonal respirations and his extremities were cyanotic. At 2 minutes, they tried intranasal Narcan, no success. They also tried an IV, which was unsuccessful. And then at 4 minutes, they tried another IV, which was also unsuccessful. At 5 minutes, they were able to place an IO, and they repeated his vital signs, noting that his heart rate was 132. His blood pressure was 82/54. His intrinsic respiratory effort was 4, and his SpO2 was 82%. At 6 minutes, he got 2 milligrams of Narcan through his IO. At 16 minutes, they did administer 500 milligrams of ketamine, but this was a calculation error. This was to be for RSI. At 17 minutes, they recorded another set of vital signs, heart rate 115, blood pressure of 80/41, no respiratory rate was recorded, SATs of 77%, and they gave him 150 milligrams of succinylcholine. They suctioned him at 18 minutes. At 19 minutes, he was intubated with a 7.5 tube orotracheally. At 20 minutes, they got another set of vital signs, heart rate of 107, blood pressure of 71/38, no respiratory rates recorded, SpO2 of 79, end-tidal of 41, and a blood glucose was 113 milligrams per deciliter. At 22 minutes, they initiated norepi to treat his hypotension. At 26 minutes, they gave him 100 micrograms of fentanyl for post-intubation sedation. At 29 minutes, they initiated transport, and at 40 minutes, he arrived to the hospital. So in reviewing this case, getting IV access after 2 missed lines, you may have a lower threshold to get an IO if you see evidence of IV drug use, which would suggest that he might be a difficult IV stick. They looked for reversible causes by giving him Narcan and checking the blood glucose. Serial vital signs were obtained. They managed his airway, and they did manage his hypotension, although I would suggest that doing that prior to intubation. And the same with managing his hypoxia before intubation, if any way possible. So areas for improvement, we have limited history of this patient, so consideration of spinal injuries, getting a 12 lead, especially in a patient that you suspect that might be drug related, as this could be an overdose or a suicide attempt. And then RSI induction meds. If you don't have a history for these patients, I would strongly encourage not using succinylcholine, especially if there's a potential that they're an acute kidney injury or they have chronic kidney disease. So in replace of succinylcholine, consideration of rocuronium. And then the point here for communication to the hospital, they communicated that the patient was intubated and altered, but not that the patient was hypotensive and on pressors. So that's helpful for us, at least at Peace Health, when we know if the patient is on pressors, because that usually means that the pharmacist is going ahead and mixing up a pressor for us to start as soon as the patient is moved over. I don't know if that's the case as well for Salmon Creek. Dr. Mott, can you speak to that?
I mean, it's definitely helpful to know if the patient's on pressors.
So in the emergency room, his initial vital signs, he had a rectal temp of 108.9. This was last month, so it wasn't particularly hot out. A heart rate of 111, a blood pressure of 50/41, despite the norepi that he came in with, a respiratory rate of 18, and he was being ventilated. Physical exam was the same as EMS had reported. The only thing is that he had significant modeling to his extremities, and they were very cold. We placed him in spinal precautions. We worked him up as a multifactorial, so sepsis, potential overdose, started with antibiotics, and because of his significant hyperthermia, he got active cooling. Our active cooling, until we were able to place a cooling catheter, looked like this. So we grabbed a sheet, dipped it in ice water, and wringed out most of it, laid it on his chest, and started a fan. So that's something that I don't think that, I don't, with his extremities being so cool, I don't think it was quite evident how hot he was until you got a rectal temp. And then we got a 12 lead here. So you can see that he's sinus tachycardic, actually normal rhythm, but he was sinus tachycardic earlier, in that his QRS is at 100 milliseconds. He doesn't have any obvious ST elevation. IV access was obtained with an EJ and through the central line. He was given IV fluids, and despite aggressive IV fluid resuscitation, he was maintained on norepi and then added, in addition to that, a phenylephrine drip because of his tachycardia, which interestingly his EKG showed a 94. Anyway, as for his workup, he had a elevated troponin in the 1500 range, so he was in STEMI. He was in acute renal failure. His urine drug screen was positive for cocaine, methamphetamines. His lactate, I think, was 10. His pH was 7.1. He had shock liver with elevated liver enzymes, and his CK, I think, was 3000. Because we didn't have a source despite our workup, including urine and a CT of his chest, abdomen, pelvis, and head, we looked for further source for possible infection given his severely elevated temperatures. So we went and got a lumbar puncture, which did not show signs of infection. He was admitted to the ICU. During his initial intake in the ICU, they found a baggie in his rectum, which they presumed were more drugs. He apparently was a former polysubstance abuser who unfortunately relapsed in the last month. He had poor underlying function and respiratory drive. Therefore, they pursued an MRI that showed that he had a devastating anoxic brain injury, and that his family made him DNR comfort care, and he passed away on hospital to A10. So I brought up this case because of ultimately his blood cultures were negative, and they felt that his severely elevated temperature was probably related to a catecholamine overdose between the cocaine and methamphetamines that he was found to have in his urine drug screen. So I did a little search, what I thought would be relatively easy for catecholamine toxicity, but I found some other stuff that reminds us that there are other reasons to have excess catecholamines, such as pheochromocytoma, tumor on adrenal, and thyroid storm, but we're talking about cocaine stimulant use, so we'll call it cocaine toxicity. So cocaine comes from a plant, the coca plant in the South America Andes. The absorption is nasal, oral, pulmonary, GI, vaginal, or rectal. Because it creates vasoconstriction, it prolongs the absorption. The pathophysiology of it is that it blocks the reuptake of biogenic amines, so it works indirectly as a sympathomimetic. It also blocks sodium channels. So if you have a known cocaine toxicity, looking at 12-lead EKG, looking for QRS prolongation would be helpful. That's why I put the EKG in from the previous slide. And then it also stimulates the excitatory amino acids, that euphoric feel that people get depending on the dose that they administer to themselves. The clinical effects is that it affects every organ system, but in effort to try to decrease all of the data here, I'm just going to cover basically the top 4, but increases the heart rate, blood pressure, alertness, arousal, euphoria, self-confidence, and performance. In the cardiac realm, that, like I mentioned before, tachycardia, hypertension can lead to arterial vasoconstriction. It increases the probability for thrombus formation, and it also increases the myocardial oxygen demand. So these patients can have chest pain and have legitimate cardiac function abnormalities, such as an STEMI or a STEMI, with the use of this, and it has a negative inotropic effect that can exacerbate patients that have a history of heart failure. Central nervous system wise, it can lead to headaches, intracranial bleeding, seizures, which can be protracted. I've had a case where a patient had continuous status seizures that were refractory to most every benzo that we had, and that was because this was a drug mule who had a ruptured baggie and probably had a slow catecholamine absorption for hours and really exacerbated all of their catecholamine reserves. It can lead to psychomotor agitation, which increases their chances for hyperthermia coupled with the vasoconstriction. If they are hyperthermic, 33% of them will that are hyperthermic because of cocaine toxicity could lead to death, and then coma. GI and renal, it increases their chances for perforated ulcers, as well as ischemic colitis and intestinal infarcts. Pulmonary wise, if they inhale it, it can lead to burns and angioedema, as well as exacerbate underlying reactive airway disease. And because cocaine is known to increase thrombus formation, it puts you at higher risk of PE. And then if the patient is trying to prevent exhalation of cocaine, they're at higher risk of having a pneumothorax, pneumomediastinum, or pneumopericardium. Treatment is going to be ABCs. From what I could find in the data, they recommend against using succinylcholine with a known cocaine toxicity because it potentiates the cocaine. In recollection, the enzyme that helps metabolize cocaine is also used for succinylcholine. So if you use succinylcholine in these cocaine toxic patients, it can prolong your succinylcholine effect, and it can also prolong the metabolism of cocaine in that patient. IV fluids, because these patients tend to be dehydrated, they can be hypertensive, and they can also be hypotensive depending on how severe their toxicity is. Typically, we will deal with benzos in patients that are complaining of chest pain and potentially hypertensive. But some of these patients will present hypotensive. So after IV fluid resuscitation, consideration of pressors. 12 leads can be helpful for looking for QRS prolongation. And then if these patients are hyperthermic, active recooling, trying to lower their temperature to their homeostatic temperature within the first 30 minutes is ideal. So in our protocols, I think that the most appropriate, besides RSI And spinal precautions would be poisoning and overdose. So looking at making sure that you're using universal precautions, managing shock, which this crew did manage with IV fluids and pressors, altered mental status, which they also followed down that pathway, as well as airway management, following down that pathway. In specific to hyperadrenergic states, so we'll go down to F under specific poisoning overdose treatment. And these are patients that are either MDMA, methamphetamine, or cocaine users, that the mainstay is going to be for benzos in the form of midazolam, 2.5 to 5 milligrams IV IM every 5 minutes as needed. If the patient is in stable VTAC with a pulse, the option is amiodarone, 150 milligrams. In addition, if they're in VFib, you would treat them in standard protocol, except for you would try to limit the amount of redosing of epi to 1 milligram every 5 minutes. Anyone have any questions, concerns, things they want to talk about on this case?
Dr. Gabba, is there any documentation of what they did to try to get the oxygenation up before RSI?
No, there wasn't any. So that's a good point to, I think at least what you're getting at is that that we would be actively trying to increase their oxygenation. They'd potentially consider DSI.
Yeah, I think so. I mean, I would lean towards that. Because these are the patients that can really crash when you push the paralytics. So I would just try to do everything you can to optimize the physiology before you push the paralytics. And then the last comment, I'd have patient got fentanyl about 20 minutes after getting Narcan. Just a reminder that you'll get less bang for your buck out of your fentanyl, but your ketamine can help you there if you need to keep the patient calm after you've given Narcan and intubated.
And this crew had said that they didn't dose the ketamine because they had overdosed the ketamine in the beginning.
No, I understand. I think that's reasonable here, and thankfully, ketamine has a pretty wide therapeutic range.
Yeah, especially after intubation. I see in the comments that Engine 62 can't see the screen. Is that fixed for you guys? I see that Mark had said. Can you see the screen now?
It might be a device issue, so we'll try it on.
Okay, no problem. Next case, unless anyone has anything about case 2. All right.
Oh,
Dr.
Dr. Gabba, what was the respiratory rate on their arrival?
4.
Okay.
I mean, they didn't get one. Well, the prior 2 didn't record a respiratory rate, but the first one on the transporting was 4.
Right. I was thinking before before using the Narcan.
Yeah. I think that they were probably going off the agonal, but
Yep.
it wasn't documented. All right. So next case is going to be of a 1-year-old female. Transporting agency was called to a local fire department for a 1-year-old. The chief complaint was shortness of breath. The patient was being held by the mother, although that was a picture of a male, but they indicated that the patient was awake, her airway was open, she was unlabored in her respirations, she was pink, warm, and dry without signs of bleeding. She seemed to be doing well in mom's hands. Vital signs prior to transporting agency's arrival had a heart rate of 117, a blood pressure that wasn't documented, a respiratory rate of 40, and an SpO2 of 100. They did check a blood glucose, which was 35, and they checked her temperature, which was 97.1, and then her weight was documented at 10.4 kilos. The only past medical history that was provided prior to this problem was that she was diagnosed with COVID, I think a few months earlier. but presumably no longer actively infected. She was currently on amoxicillin and for an ear infection, which is in the HPI. She woke up crying, and her parent noted that her lips were cyanotic. Mom says that her mental status is normal currently, and I think even at that time, mom thought that she felt a little hot earlier, so she gave her some Tylenol, but she didn't actually document a temperature on the child, in that she was recently diagnosed with an ear infection for which that she was currently on amoxicillin for. The narrative from the transporting agency was that her diapering was normal and that they documented normal birth weight and no complications. A little vague onto no complications, not certain if that's in regards to pregnancy or delivery, but nonetheless, mom says that all the symptoms that she had brought her to the fire department for were resolved at this point. It's always good in our pediatric patients to pull up the normal vital signs. So you may kind of think, oh, these look all okay besides maybe this blood glucose, but she's also pretty tachypnic. Well, I shouldn't say pretty, but she's outside the normal range of respiratory rate in a 1-year-old. So that's something to consider, especially if she doesn't look like she's crying or labored or anything like that. This call was patient contact occurred for the transporting agency at 10:58. First set of vital signs in the 7 minutes, which I reported to you guys. Physical exam documented as normal. They did check a blood sugar. They checked breath sounds. They checked cap refill. They documented GCS, so pretty thorough. They initiated transport at 8 minutes. They recorded a heart rate of 121. At 13 minutes, they reassessed her vital signs, heart rate at 133, SATs of 98%. 18 minutes, they checked another set of vital signs, heart rate 122, which is within normal, up to 140 is normal for a 1-year-old, and SATs of 100 at 23 minutes, her heart rate largely unchanged, and same with her SpO2. And at 28 minutes, they arrived to the hospital. With an abnormal respiratory rate, ideally we'd be monitoring that besides just SpO2. So good, they checked a blood glucose for what they later described as a bruit. They were really thorough in their physical examination of this patient. They got serial vital signs, albeit I'd like to see respiratory rate recorded, especially any abnormal vital sign to be trended. And then they initiated transport as opposed to had the patient go POV or refused. Areas for improvement would include treatment of hypoglycemia. In the emergency room, she was treated for hypoglycemia with glucose. Her workup noted that she had ketones in her urine and that she had an elevated beta-hydroxybutyrate concerning for possible DKA. She was transferred to Randall's, and I think Dr. Mock, and when we discussed this previously, she was transferred not just because of these values, but because she was refractory hypoglycemic. Is that right? I think so.
Sorry, did you have a question?
Yeah, I was going to say, wasn't she not, she was transferred to Randall's because she was persistently hypoglycemic, right?
Yeah, I mean, she needed kind of a couple of doses of dextrose to keep her sugar up, and it wasn't tolerating a lot of oral intake. So that was the reason she was transferred for an inpatient admission.
Yeah. So at Randall's, since you're on now, but you don't have to, I don't put you on the spot. At Randall's, her hypoglycemia was eventually corrected with both PO, IV, dextrose, and initiation of a diet. Peds endocrinology was consulted, and she was diagnosed with ketotic hypoglycemia, which they thought was most likely nutritional deficiency and depleted glycogen stores because of 2 weeks of a diarrheal disease secondary to cow milk intolerance and the antibiotics that she was initiated for her ear infection. So we brought up this case because of the fact that there was some question to management of glucose abnormalities in pediatrics, and it led to some discussion of changes in our protocol. But in regards to hypoglycemia in children less than a year old, it's pretty rare. Morbidity is going to be more related to seizures, if there's brain death or brain damage, I shouldn't say brain death, brain damage that might manifest itself as like developmental delay or disability, and death if it's not identified and treated eventually as the glucose continues to trend down. The differential diagnosis is many, but in this age group, the vast majority is due to fasting or poor PU intake or GI losses, as was this case. So this picture here on the right, it's a little hard to see, but I'll just kind of explain it. So as the blood glucose levels become low, the body works to create glucagon that releases to the pancreas, which causes the islet cells in the pancreas to produce glucagon, which stimulates the liver to break down the carbohydrate stores, the glycogen stores, to create sugar. So in our pediatric patients, they have a higher propensity to for the glucose levels to decrease and to transition to ketogenesis earlier than in our adult population. Clinical features are going to be twofold. We're looking at neurogenic or autonomic. So these are going to be things like sweatiness, tachycardia, palpitations. They may have the sense to need to eat, depending on how old this patient is. And there may be neuroglycopenic changes, and that's going to be related to insufficient glucose to the brain. So they might be lethargic, confused, irritable, seizures, especially if their glucose is under 50. And then infants and toddlers are tough because they can be pretty nonspecific as well. So they may just be cyanosis, poor feeding, lethargy, irritability, jitteriness. So they're not always as straightforward as our adult population. In the diagnosis of hypoglycemia, it's more specifically when the glucose levels are low enough to cause signs and symptoms of brain dysfunction. Although they did break it up into 3 categories. So normal, after the first week of life, it should be 70 to 100 milligrams per deciliter. They do note that up to, I think it was 48 hours after birth, that, let's see my notes here. Oh, I don't know. But anyways, after, I think it's the first 48 hours after birth that there can be a transitional hypoglycemia. So it wouldn't be uncommon for the blood glucose to be 59 plus or minus 11. But after the first week of life, it should be the 70 to 100 range. The diagnostic criteria for hypoglycemia is under 50. And then the treatment goal is to get the glucose above 70. In the literature, that's not quite what we have verbatim in our protocol. So if the patient's conscious, you're going to be aiming, especially in these pediatric patients, you're going to be aiming to replace them with 15 grams of glucose, and that could come in the form of glucose gel, glucose tablets for them, or 4 ounces of juice. If you don't think that they can adequately protect their airway, they're an aspiration risk, or they just can't follow commands to swallow, then these would be patients that you would start an IV in them, and you'd be giving them 10% solution, 2 mLs per kilogram. And then if you felt that IV access and glucose wasn't leading to normalization of their glucose, you could also consider glucagon. If they're under 25 kilos, 0.5 milligrams, and if they're over 25 kilos, 1 milligram.
Dr. Gabois?
Mm-hmm.
In this case, though, I would caution using glucagon because the child was clearly glycogen depleted already, and the glucagon would only probably cause more hypoglycemia.
Yeah.
Or do nothing.
I was gonna say more. I mean, one, they didn't get a history of GI losses, so I don't know if they would have necessarily thought there was no glycogen stores for the patient to have access to. But I think like if you don't know, and you have somebody who's potentially really sick, their glucose is low, they can't protect their airway. I think that it would be reasonable to try glucagon, because even in our alcoholic population, we assume, or other people that have poor nutritional state, that it's unlikely to be helpful because they don't have any glycogen stores. But I don't know if it would necessarily, besides pain from an IM injection, would be necessarily detrimental. But I don't know that for sure.
I guess that my main point is that I discourage the use of glucagon pre-hospital.
Yeah.
Over if they can take orals, give them orals. If they need glucose, they can get it IV. You can even give it IO, but it's not as easy to do. And I don't think everybody needs an IO. So glucagon is the last ditch
Absolutely.
thing.
Yeah.
It
And then in this, go ahead.
it won't work if you're depleted. Anyway.
Absolutely. It'll be a wasted
Yep.
placebo. But in this case, the feedback to the crew was that this patient was awake, alert, in that they could either have given the child a bottle of formula or juice, in that in speaking with the medic of record, he had said that in the future he thought he would just put some glucose gel on the pacifier or in a bottle and have that. I think the bottle might be a little bit harder, but I think he was speaking because of the viscosity. I think he was speaking more onto like the pacifier because the patient was awake, alert, protecting her airway, and seemed to be able to take in PO. So I thought that there's two protocols I thought that this case kind of showcased. And the first would be BRUI, so brief resolved unexplained event, lasting less than a minute in an infant, I'm going to say up to or less than a year old, with either cyanosis or pallor, decreased or regular breathing, change in muscle tone, or altered level of consciousness. So the cyanosis is what would fall under this case for this patient. Supporting ABCs, managing their airway, or identifying respiratory distress and managing that. Obtaining past medical history, so complications in pregnancy, the gestational age at birth, if there were any complications with delivery, if there were any infections, prior BRUI episodes, any other underlying known medical conditions. And then documenting the symptoms, anything that might have been inciting, any resuscitation that was provided by EMS, trying to place them on the monitor to evaluate if there is any arrhythmias, making sure you check a blood glucose, and transporting via ALS to an emergency department, even if the infant currently appears in no distress. So I thought that besides the identification of hypoglycemia, they did a pretty good job of following our BRUI protocol. And then that leads us to hypoglycemia for altered mental status. So less than 60 for an adult. If patient can protect their own airway, give oral or complex carbohydrates. If unable to protect, you give dextrose. So in pediatrics, I believe this is our old protocol. Mark, did we update that? No, this is our current one. So we got rid of, it's still the old one. It's the 10 kilos. Is that right, Mark?
This looks like the old one.
Yep.
Yes. So this was the old one because the crew had some difficulties with the weight and the age. So if I remember correctly, we are going to change the protocol to be about chronological age. And I thought we agreed that it was going to be a blood glucose less than 60. That sound right for everybody?
Correct.
Cool.
Yeah.
So that'll help in helping us in determining hypoglycemia and getting the weight and age out of the mix for trying to figure this out. Any other questions, thoughts for that case?
No, I would just say, like, as I was reviewing that case, I think this is I think there are things that the medics could have done better with respect to the glucose, but I also think as medical directors, this was something where we felt like we needed to improve what we were doing and make the protocol clearer and easier to follow. And so the key thing is physiologically, the transitional hypoglycemia is in the first week of life. And then after the first week of life, with respect to glucose, you can just think of kids as small adults. And then but then if you find the hypoglycemia, then definitely treat it, especially in an awake alert kid. It's a very low risk intervention to give the kid some oral glucose by whatever means you can. The last thing I would note is that if you find hypoglycemia, especially in an infant, one of the other things we have to think about inborn errors of metabolism, which can sometimes be unmasked when the kids get nullus, but you also have to think about neglect as well. An infant that's being neglected can be hypoglycemic from being chronically undernourished.
Yep, yeah, that's a good point. Thank you for those considerations, Dr. Mock. Moving on to our last case, it's a case of a 77-year-old who was jaundice and altered. EMS is called for altered mental status. They find this patient responsive to verbal stimuli. His airway was open, but he wasn't protecting it. He was jaundiced, he was hot, he was dry. There was no signs of active bleeding. Vital signs were obtained by the fire crew that had arrived first, noted to be tachycardic at a rate of 120, blood pressure 94/57, respiratory rate of 40, and SpO2 of 77%. The past medical history that was provided by family who were on scene said that he was diagnosed with lymphoma and it was somewhere around his liver. The meds that he had for his chronic illness was ursodeoxycholic, tamsulosin, furosemide, allopurinol, omeprazole. And the history was that he underwent a second round of chemo for his lymphoma. The family had seen him the previous night, but they had spoke to him earlier in the day of this incident, and that they came over and found him altered on his toilet. He hadn't fallen as far as they could tell. The fire department had moved him to the bed prior to the transporting agency's arrival. Prior to the transporting agency's arrival at 6:49 p.m., 5 attempts at IV access were initiated in a 14-minute interval before the transporting agency arrived. They found the patient to be semi-conscious on bed with the fire department attending to him. They placed him on a non-rebreather mask at 1 minute. They noted that the patient was unresponsive. He was hot, dry, jaundice, and cyanotic. Last known normal was that they seen the patient was the previous evening around dinner time. At 16 minutes, they decided to move the patient to the ambulance. His heart rate was 127. No blood pressure was recorded. Respiratory rate of 38. Untitled 25. And IO was placed at this time, and he was given a liter of IV fluids and 40 milligrams of lidocaine. Family had stated that he was a full code. At 22 minutes, they obtained another set of vital signs, heart rate 128. Now, the second blood pressure, 101/48. Respiratory rate of 36, SATs of 100% on that non-rebreather, and end-tidal at 23. At 23 minutes, they placed a second IO. He got 120 mLs of IV fluids in that, and he was started on 8 micrograms per minute of norepi for his hypotension. At 25 minutes, they initiated transport. At 28 minutes, they repeated his vital signs, still tachycardic at 130. His pressures are a little bit better at 103/48, respiratory rate of 36. His SpO2s dropped down to 85%, and his end-tidal is largely unchanged at 24. At 41 minutes, the crew moved towards RSI, but before they moved towards RSI, they had documented that they were doing everything they could to optimize his hemodynamics before moving towards intubation. They also documented that they did a half dose of ketamine due to concern for shock, and that they chose rocuronium over succinylcholine because they didn't know, 1, his underlying kidney function, and 2, if he was an acute kidney injury. At 42 minutes, they had him on apneic oxygenation with the use of a 15-liter per minute nasal cannula. With the use of video laryngoscopy and bougie, they were able to place an ET tube on first pass. At 43 minutes, They did another set of vital signs, heart rate now 143, blood pressure 102/37, no respiratory rate is documented, end tidal of 38, and they have a temp of 101. Just to kind of remind you about what the end tidal is before intubation and after intubation, and maybe some intubation goals. At 46 minutes, they place him on a ventilator. They document a rate of 20, and they have a 100% FiO2, PEEP of 5, and positive inspiratory pressure of 20. At 47 minutes, they repeat another vital sign. Heart rate's 141. Blood pressure is 166/74. I think that they didn't record respiratory rates because they were using the ventilator and assumed that the rate should be what it was set at. But I think that we should still put respiratory rate in here too. SpO2 is 100% now, and end tidal is moving towards the value that he was pre-intubation at 29. 49 minutes, they give him 100 micrograms of fentanyl. At 51 minutes, they repeat vital signs, which now the only difference is that his pressure is kind of more normalizing at 121/56. They did notify the hospital that they were transporting to that they used a longer acting paralytic so that they weren't assuming that the patient had no physical response because of the fact that they used a longer paralytic.
Dr.
So
Gagwa,
Mhm.
can I ask a question back? I see that, did they document why they gave him the 40 milligrams of lidocaine? I'm assuming that's after the IO.
Yeah, I think
But
that
but
was, go ahead.
they also document that, I mean, on the PE, it says he's unresponsive. So
I think that there was a little bit of conflicting. So I think that it may have been kind of waxing and waning. So the fire department documented that he was responsive to verbal stimuli, and that kind of speaks to the fact that he was sitting upright on the toilet. So I don't know if he became more unresponsive or if they did document, the transporting agency documented that he was unresponsive, but they, in the same narrative, they documented that he was semi-conscious. So I think that there may have been some transition between mental status states.
I'm assuming then that they thought that the 40 milligrams of lidocaine was for pain from the IO, although I would be a little reluctant to use much lidocaine in a patient who's clearly got altered liver function.
Yeah. That is a good point for toxicity and difficulty with metabolism since they're impaired liver function. This is a case that Dr. Mock had submitted. So most of the stuff is his feedback, but I don't know, Dr. Mock, you okay with me giving your feedback, or do you want to give your own feedback?
Go ahead.
Okay. So he documented excellent job working as a team for patient care, given the two agencies working together for this patient. And specifically with AMR, he documented that he agrees with the decision to intubate, wise decision to decrease the ketamine dose given shock and to use ROC given prolonged downtime. Could intubate on scene if conditions permit, but it sounds like it was appropriate to do en route here. Wise to start norepi. Make sure you are giving fluid boluses as well. Appropriate analgesia after intubation. His room for improvement suggestion was consider moving to IO sooner. As you remember, 14 minutes prior to AMR arriving, 5 IV attempts were made, and I think it was 16 minutes after. So we're talking about 30 minutes after patient contact before first IV access in the form of IO is started. The only other things that I would add would be, if you have time allows, checking a blood glucose. 12 lead on a patient that, could be an arrhythmia, could be a STEMI, but also could be renal failure, leading to electrolyte derangements. And then consideration for what their end tidal is prior to intubation and post-intubation. We saw that right after intubation, his end tidal went to 38, but as they continue to ventilate him, at his rate of 20, presumably on the ventilator, his end tidal started to go back to his previous intubation end tidal. And then make sure that you document your respiratory rates, even if they're on the ventilator. So in the emergency room, he was maintained on pressors. There was no clear source for infection, but he was neutropenic. Low white count is what neutropenia is, and that puts you at impaired ability to fight off infection. And they thought that he was neutropenic from chemotherapy. His hemoglobin was low at 6.7, so he was transfused. He was found to be an acute renal failure with rhabdomyolysis, and they suspected that he had tumor lysis syndrome after starting chemotherapy. I don't have the full course for him, but in 3 days into hospitalization, I have. So he grew Enterobacter bacteria in his blood, bile, and urine. He was being weaned off norepi, but he's still on dobutamine. He was getting continuous renal replacement, which is like dialysis, except for patients that are too sick to be on dialysis. And that he was intubated by hospital day 3, but they were planning on spontaneous breathing trials. I don't know what his ultimate outcome was because I couldn't pull him up from my access. But unless anyone else knows about his final outcome. So this was a good case to talk.
Improved and was discharged. But
He improved and was discharged. Excellent. See. So this was a great case to talk about tumor lysis syndrome. So it's considered an oncological emergency, and it's when the tumor cells lyse or die, and they release all of their contents into the circulatory system. So there's large amounts of potassium, there's large amounts of phosphorus, and there's large amount of nucleic acids. The nucleic acids increases your uric acid, which your kidneys work to remove, but they also can impair the renal function, which can lead to acute kidney injury. As phosphorus binds to calcium, depleting your calcium stores, it increases your chances of precipitation in the renal tubules, which also leads to kidney injury. And even if your kidneys work normally, you have higher potassium levels, but then combining that with 2 reasons for you to have acute kidney injury, your potassium can be markedly elevated. So the definition is going to be, so labs and clinical features. So labs that are abnormal, such as potassium, phosphorus, uric acid levels, kidney function, and clinical features would be if they have elevated creatinine for acute kidney injury, cardiac arrhythmias because of their electrolyte derangements, either in the form of potassium, but less so in the form of calcium, or if the patient moves on to have a seizure. So those are your definitions, your lab and clinical features. Mortality for these patients, the major cause of death for them is going to be acute kidney injury and cardiac arrhythmias. In prevention, if they have a condition that they either think is at high risk for tumor lysis syndrome, and then these are going to be patients that have an aggressive lymphoma, or that they have a large tumor burden, or their tumor has high proliferation, or the tumor is thought to be highly sensitive to cytotoxic therapy, they can move to prevention. But just so you know, it can also be spontaneous lysis. But if they have one of those conditions, then they would be giving them IV fluid hydration to try to help with clearance of these end products of the tumor cells. And then they can also be giving them a hypouricemic agent such as allopurinol. And if you remember correctly, this patient's med list did include allopurinol. So not sure if they had a known history of gout or if this was for prevention for this patient. And then treatment is the mainstay is going to be IV fluids, monitoring your urine output, which is partially can be done in the pre-hospital setting, but also the urine output is being more monitored in the hospital setting. And then measuring the electrolytes if we have the capacity to do so. So that's hospital setting, but having a high index of suspicion. So in the pre-hospital setting, getting an EKG, treating hyperkalemia if it's suspected, and making medication adjustments to prevent adverse response. So the crew's decision to move away from succinylcholine and to use reduced dose of ketamine because of the shock state of this patient. And then the treatment, if the kidney function is continuing to rise, if they're anuric, oliguric, or if the potassium is refractory to treatment, would be renal dialysis, either in the dialysis or CRRT or CRV, I think, form. Anyone have any questions, thoughts about tumor lysis syndrome before I move to our protocols? So in regards to this patient, altered mental status, this patient was altered and sometimes reported to be unresponsive. So looking for glucose abnormalities, considering opioids. And then the next protocol that this patient fell under was shock. Is this patient hypovolemic, giving IV fluids? Is this patient potentially in sepsis? He's febrile, he's tachycardic. So in addition to IV fluids, consideration of pressors, starting at 4 mics per minute and then increasing every 5 minutes to 4 with a max of 12 mics per minute. Cardiogenic would be helpful for a 12 lead. And then if you think that the patient might be in adrenal crisis, steroids. And then sepsis, this patient also fell under the sepsis category, which is all the reasons, 2 or more. So he had a fever, he had a tachypnea, he had an elevated heart rate, he had a low end tidal, he was altered, and they treated, I think, a liter, like 1,120 mLs of IV fluid, so up to 2 liters, watching for signs of volume overload, such as in JVD or RALs with assessment of lung sounds, and then adding pressors, ideally norepi, but you can use epi as well. And then lastly is just intubation, highlighting the fact that this crew identified correctly, trying to pre-oxygenate them in order to improve their SATs prior to intubation. And then also recognizing that if the patient's in a shock state with a MAP of less than 65, the dose of induction agent should be cut in half, which they did. And if they thought that this patient was at risk for hyperkalemia, to use rock over sucks, which is exactly what this crew did. Anyone else have any questions?
That's a very nice job, really.
Mm-hmm. And really well documented too.
Yep.
Dr. Gabois, there's a question in the chat. I don't know. Can you get to the chat?
Yeah. Half dosing induction med in shock or concern for shock has been removed from protocol. Should we still be? Well, that's the protocol I just had there was the current form. I believe it's the one that I pulled off the protocol list. So
Yeah, that's the current one. I know there was some discussion about, there's been some discussion about that previously, but as of our current protocol is if the patient's in shock to half dose of induction meds, that's current.
oh yeah, and then they said, never mind, this is still there. But I remember what we're mentioning, removing it. No, I think that it's appropriate that we still have it. But it's a good thought. I mean, these are the kind of things that we want to be thinking about at like a higher level instead of just grabbing the things because they meet the boxes. It's the subtle consideration that helps us identifying the most appropriate treatment for these patients, for all of our patients. Well, so the cases that we talked about today was medically caused abdominal eviscerations, that there is such a thing, and that in a lot of ways they're treated just as significantly as your traumas. They don't always have to be code reds or code 3s, depending, or trauma activations, especially if there is no trauma associated with them. And notification to the hospital so they can appropriately place that patient in a room that would not include the triage area, and documenting that this exam occurred, and that you're treating that evisceration with sterile saline gauze, or saline gauze. There's not really anything really sterile anymore at that point, and IV access if possible. Stimulants, we see a lot of meth, but don't forget that there's other forms of stimulants, cocaine as well, and that we tend to see them as like an agitated state or maybe chest pain state, but it can actually cause them to be quite hyperthermic and in some cases hypotensive. So IV fluids, IV access, ABCs, and identifying any blood glucose abnormalities, getting a 12 lead, watching for sodium channel blockade or QRS prolongation, and managing hyperthermia aggressively if we identify it. But they're complicated patients because, this patient, assuming he's an IV drug user that we talked about, he could be septic, bacteremic, endocarditis. So they're just multifactorial patients. Pediatric patients, if they're hypoglycemic, So our marker is under 60 after the first week of life. We're going to treat them. That might look like in the form of PO intake, but it could be in the form of IV if they can't do PO intake reliably. And then tumor lysis syndrome can be spontaneous, but most likely is after initiation of chemotherapy for our lymphoma patients, and it increases their odds of having renal failure as all of their tumor cells lyse, so increasing the potassium, increasing their chances for renal failure, compounding the potassium problems, so 12 lead, resuscitation, IV fluids, and monitoring and treating what we can in the electrolyte abnormality range, the pre-hospital setting. So here's my references, and happy EMS week, everybody. Thank you guys for what you guys do this week, but every day of the year as well. Anybody have any other questions, concerns, thoughts?
Just if I could, a brief reminder, thank you everyone for adapting to the color acuity system. Just please do not use code in front of the patient acuity. Code red is the hospital code for fire. Code green sounds a lot like code 3. So just describe the patient acuity. But then just to second what Dr. Gadbois said, happy EMS week and thank you.
Great. That's all I have for you guys.
Thank you, Dr. Gadbois.
Yeah.
Thanks,
absolutely.
Dr. Gadbois.